I am an intensivist. I work in one of the hospital environments where there is mostly technology and high-tech treatments. That's how people usually think about intensive care. But intensive care units are mainly about people. The relationship between all these people in the ICU are so important. The dynamics of the team, but more importantly, the relationship that we build with the patient and the family.
Sono rimasto particolarmente colpito dal pronto intervento ogni volta che avevo necessità, sia a livello fisico che psicologico. Il personale interveniva sempre con molta affabilità, quindi molto gentilmente. Mi sentivo veramente accudito e protetto in ogni momento della giornata. Quindi da questo punto di vista sono rimasto molto soddisfatto. Venivo inoltre informato su quegli aspetti clinici che avrei dovuto subire da quel momento in poi, quindi mi veniva spiegato nei dettagli cosa avrebbero fatto e come lo avrebbero fatto. Al momento del risveglio non avevo ovviamente le idee molto chiare, stavo vivendo due realtà diverse, una quella vera in rianimazione e un'altra che era quella degli incubi, per cui il primo periodo non avevo ancora capito bene quale delle due era vera. Solamente dopo aver parlato ripetutamente con i medici che mi rassicuravano e mi spiegavano appunto questo fenomeno degli incubi e soprattutto anche dopo aver parlato con mia moglie al telefono, ho capito qual era la vera realtà. Le due realtà erano vissute ambedue dentro il reparto, quindi per me era difficile distinguere. L'ingresso di mia moglie in terapia intensiva è stata una inaspettata e piacevole sorpresa. Non ricordo molto di quel momento, le parole soprattutto, però ricordo benissimo le sensazioni e lo sguardo di mia moglie. La terapia intensiva è un'esperienza sicuramente molto dura e viene vissuta probabilmente in modo diverso da ognuno di noi in base al proprio carattere. Il messaggio che posso mandare è un messaggio di fiducia e di speranza, in quanto dobbiamo totalmente metterci nelle mani del personale sanitario che ha la formazione corretta per gestire soprattutto gli aspetti, oltre che quelli clinici, anche gli aspetti emotivi della persona e quelli psicologici, che sono, secondo me, forse per il paziente e la famiglia gli aspetti più importanti.
You are the spouse, you are the brother, the sister, the parents, the children of an ICU patient, you are a friend. All of you are family members. Of course, we are not going to have the same communication with any of you according to what's the relationship between you and the patient, but we are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
The team was so human and kind. They helped me psychologically every day. I was waiting for the call every day with impatient. So that period was really very hard for my family. The team of ICU became really my family. I felt them closer even than my parents. Every day someone from the team called me and informed me about the situation of my husband and the next steps to do. And I want to say that even if I was far from my husband, I have been always updated about his clinical situation. And when there were very important decisions to make, for example, like tracheotomy, they called me 5 times per day. So I want to say thank you. For me, it was a new experience, like for many other people. I have never faced ICU. So after this experience, I changed my life. I changed all points of view. It was a really very hard period, and I was about to lose my husband, but I have never lost hope, and I tried to be strong and rational. I remember my first visit in ICU very well, because it's impossible to forget. It was so emotional. After 64 days, finally, I could see my husband, touch his hands, see his eyes. It was really very difficult to live without him and without personal contact. I don't have enough words to say Thank you to the doctors for that possibility that they permitted me to visit him in ICU. Thank you very much. I'd like to say to the future patients and their families that they should trust to the staff of ICU. They're allowed in the hands of professionals that work tirelessly with passion and love. They are always with the patients. The patients are the primary focus for them. They always gave the warm care and necessary treatment. They never leave alone patients. They are always with them and ready to help them in any moment. The patients are the primary focus for the staff. At the end, I want to say, no matter how ill is the patient, don't give up hope.
Having a loved one in the ICU can be an extremely distressing experience. Some family members suffer from symptoms of anxiety, of depression, some feel lost or even disorientated. So don't forget to take care of yourself. Sometimes you will need to take a break. You don't have to stay with the patient 24 hours a day, and you mustn't feel guilty if you do need to take that break. Don't forget that the ICU team will continue to care for the patient while you're not there, and they will always call you if there is a change in his or her condition.
My name is Silvia. I'm a critical care nurse. I work in an intensive care unit. My work is to assist the doctor and to help them to prepare the patient to get all the medicines and the treatments they need in the ICU. When the family first enters in the intensive care unit, I will receive them and welcome them and present them the room and the patient and explain the condition of the relative. I will be there to receive also their emotions, how they are feeling about it, and explain them what the patient is feeling at the moment, what we are going to give them for treatment. We will be there in any case to help them to go through these days in the intensive care unit and to perceive and communicate with the patient. We will be there to help him and assist him to the toilet, to the feeding, and to do anything that the patient will not be able to do. But moreover, we also will be there to see how is he feeling, if it's uncomfortable, if it's in pain, to learn to communicate with him all over the stay with all the equipment he will have. We will explain them the things that will happen to him and to his family, and to interact between the doctors and the patient.
The main role of a physiotherapist is the rehabilitation of the patient. With the term rehabilitation, we mean restore the previous situation that the patient had before his or her injury, his or her trauma. And so the patient could have again his or her previously autonomy in the best way it could be possible. A physiotherapist could work inside the intensive care unit, so it is a member of ICU team for all his or her working time, while in other countries the physiotherapist comes to ICU just only for the rehabilitation moment.
Hello, my name is Stefan Schaller. I'm an anesthesiologist and intensivist. As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients. My role is to coordinate the healthcare team to do the diagnosis and the treatment of the patient. To you, as a family members, I have to explain what is going on with your family member in the ICU. I explain to you what we are doing for diagnosis. I tell you the options for treatment and how to treat the patient. Very often, we have to discuss what are the wishes of your relatives, although he's not responsive. Therefore, we discuss together with you what is the best care we could provide for your relative. In the beginning of your ICU treatment, very commonly you are unresponsive. You will be examined by me or a colleague every day. We will make the diagnosis plan and the treatment plan. Later on, when you're waking up again, we are starting to talk with you about the treatment plan as well. While you're unresponsive, we try to discuss the care with your family, or we look at any documentation you provided, how the care should be provided for you.
As a social worker, I'm part of the ICU team. I regularly come on a daily basis to the ICU and talk with the professionals on issues with the families or with the patients. For example, when it's about communication or when there are conflicts, but also when the families have a request so that I can help them to overcome that issue. What I notice is that the families have a really difficult time. They are stressed about their loved one, but they also have, for example, issues for themselves. For example, they have questions, can I take my children into the ICU? Or how can I manage the homework? Or what can I do about financial problems? So I try to help them with that kind of issues. And sometimes they are also asking life questions, because, for example, why is this happening to me or to us? And what's the meaning of this, that he or she is going to have this critical illness? So I try to help them with this kind of issues. My relationship with the patient is to get him or her to learn him better. And I think it's very important to have the values, what is important for the patient, to have them bring into the care that we provide in the ICU. And I think that it is compassionate care, humanizing care, and that is combined with the highest technical and medical treatment that we provide. And in that way, we have excellent care that we can provide in the ICU. And I try to bring my expertise and to have the patient and his meanings and his opinions in front of it.
A special aspect in my daily practice is the communication with the patient and the communication with the families. Communication in ICU is very difficult because clinical situation is very complex and sometimes it's not so easy to explain to families. And in my opinion, the most important thing is to try to keep it very simple, not to spend a lot of technical words, but I just only try to explain the clinical status with simple words. It's very important to try to develop a relationship with the patient and try to keep it quiet, to tell him that the situation is under control. It's very important to maintain a patient calm and confident with the team, because very often the patients are very scared by the environment of the ICU. So it's very, very important to guarantee the comfort of the patient.
We work together as a single team with patients and families, and that's crucial for the recovery of our ICU patients.
Hello, everybody. My name is Jean-François Timsit. I'm a professor in intensive care medicine in Paris Bichat Hospital. And it's my pleasure to present and to moderate the live interactive session organized by the EACCME entitled Practical Microbiology Diagnosis and Management of Pneumonia in ICU, and which is supported by BioMérieux. And we have now 1 hour and a half to discuss the role of this kind of new techniques in order to optimize our way of treating our patients. And we will have two presentations. but do not hesitate to ask questions. I will have it on my phone and try to ask it during the presentation to the first speaker. And after we will discuss some case reports in order to discuss in practice how should we use this kind of test in routine when we are in front of pneumonia. So my pleasure to introduce Professor Antoine Roux for the first talk about the practical aspect of this kind of new techniques and the possible impact of this kind of new techniques. Antoine is a professor of anesthesiology and intensive care medicine. He is also leading a research unit about translational immunology, and he is especially interested in the way of diagnosis pneumonia and the role of respiratory microbiota in this setting. So Antoine, it's your turn to talk, and I will do not hesitate to ask questions to the chat, and I will translate it during the presentation. Antoine, your turn.
Okay, thank you so much, François, for the presentations. So yes, my name is Antoine Roux. I'm a professor at the University of Nantes, and I'm currently in Melbourne University for a few months. So that's my pleasure to talk today about practical microbiology diagnosis and management of pneumonia in intensive care units, and more precisely about molecular rapid identification methods. So I have a little technical issue, so I will ask you next slide regularly. So we can move to the second slide, and this is my conflict of interest. So I received some grants from bioMérieux and MSD for research on pneumonia. So we can move on the next slide. So we all know that hospital-acquired pneumonia is a medical matter of concern. First, because it's a very frequent hospital-acquired infection. Roughly 20 to 25% of the patients in intensive care units will develop hospital-acquired pneumonia. And in Europe, it's roughly 500,000 episodes every year that has been declared in the last years. These frequent hospital-acquired infections are also severe because they have an important impact on the patient outcomes. We know for sure that it will increase the duration of mechanical and invasive mechanical ventilations, increase the duration of hospital durations, but it can also increase the risk of death and in ICU mortality, notably in case of late episode of hospital-acquired pneumonia. So on the next slide, we can show that one of the main questions when we have patients developing such severe conditions is what is the optimal delay to initiate the antimicrobial therapy, because actually antibiotics are the only treatments recommended to treat hospital-acquired pneumonia. So you are in front of a patient, he's presenting symptoms and chest X-ray compatible with the diagnosis of hospital-acquired pneumonia, and you will have you will need to take the decisions to treat this patient with the best antibiotic. You don't have a lot of time to select the best antibiotic, because we know that every hour between the diagnosis of sepsis and the initiations of efficient antibiotic is associated with an increase of the risk of in-hospital mortality. So it has been mainly shown in severe sepsis, but it's also true for respiratory infections. So every hour of delay, you increase the risk of death. So I'm not saying that you need to initiate antibiotics as soon as you have a suspicion of pneumonia, but when you are sure of the diagnosis, you need to start the treatment as soon as possible. Meaning that you cannot wait to have a definitive identification by classical cultures to start the treatment. So you will collect respiratory fluids and start the antibiotics before knowing the pathogens causing this hospital-acquired pneumonia. So on the next slide, you will show what is actually recommended to select the best antibiotics, because you have a matter of concern regarding using too frequently broad antibiotics, which is not good for the community because it will increase the risk of antibiotic resistance in the community. And using too narrow antibiotic spectrum, and in this case, you may increase the risk of treatment failure for your patients, taking an individual risk for your patients. So actually, it's recommended to have some estimation of the risk of antibiotic resistance for your patients, knowing that if he has already received antibiotics in the previous 90 days, how long has he been in hospital, less or more than 5 days, is he known to be a carrier of antibiotic-resistant pathogen, and so on. So you have several risk factors to know. And if your patient has none of these risk factors, you can suspect that the patient is developing a pneumonia with medicine-susceptible Staph aureus or Haemophilus influenzae or Escherichia coli. And in this case, you can use, let's say, narrow-spectrum antibiotics such as acylclavulanic amoxicillin or third-generation cephalosporin. If your patients have a severe risk of resistance, you will have to use antibiotics efficient against Pseudomonas aeruginosa, such as ceftazidime, piperacin tazobactam, or in association with aminoglycosid. So on the next slide, you will see that if you follow this recommendation, what is actually what I recommend you to follow, you will have in 37% the good antibiotics, the appropriate molecules, meaning that it's not too broad, but it's not too narrow. So only one patient out of 3 receives the perfect antibiotic for his pneumonia during this period of time when you start the treatment, but you don't know yet for sure what is the pathogen in the episode of pneumonia. More interestingly, you will see that the risk of undertreatment, meaning that the patients receive an antibiotic which is not efficient, is very low with these recommendations. Only 3% of the patients, roughly, in this study, but it can increase up to 5%, but it's a little number of patients have an empiric antimicrobial therapy failure. The most common situations is an overtreatment. In these situations, it means that you are using an antibiotic which is too broad, and you may have used an antibiotic with a narrow spectrum. So this situation means that actually the recommendations tends to favor the individual risk to the community risk. So we frequently use too broad antibiotic. On the next slide, you will see that in the classical way, you will have to desescalate your empirical antimicrobial therapy. So in roughly 60% of the case, you will have to reduce the spectrum. This is an efficient therapy approach. So that is what is recommended because it's associated with an adequate clinical cure on day 7. It's not the reduction of the spectrum do not increase the risk of relapse or of secondary infections, and it's not associated with any increase in mortality or ICU mortality, meaning that this desescalation is safe and it's recommended. But in some other publications, it has been shown that clinicians are still sometimes reluctant to reduce the spectrum. And in roughly 50% of the situation, when you can reduce the spectrum, you don't do it. Meaning that if you are using another treatment at the beginning, it will last for 7 to 8 days. On the next slide, you will see that following this recommendation, which are as a summary, treatment. As soon as you are sure of the diagnosis, you collect respiratory fluids, you estimate the risk of your patients to have a resistant bacteria. You start the treatment. After 3 to 4 days, you have an identification and susceptibility to antibiotics, and you can reduce your spectrum. If you follow these recommendations, you can reduce you can enhance the outcome of your patients, and it can be shown in this study where the ICU, after implementations of this recommendation for the prevention and treatment of pneumonia, have been associated with a reduction of the duration of intensive care unit hospitalizations and a non-significant trends toward a reduction of the risk of treatment failure. The treatment success was 66% before the recommendation and increased up to 75% after the recommendations. So these recommendations needs to be applied, needs to be followed as good as possible. But yes, we need to do better, as shown in the next slide, because we still have roughly 30% of the patients we will have treatment failure. So meaning that if you follow this recommendation, which has been proven to be efficient, one patient out of 3 is still presenting with criteria of pneumonia or with respiratory failure at the end of the treatment. So yeah, we need to do better. We need to have better approach for that. And one of the hypotheses we have, and we will debate in this presentation, is that rapid bacterial identifications can help to better guide empiric antimicrobial therapy, and so reduce the risk of under or over treatments, and likely improve patients' outcomes.
Okay, perhaps to start with the question, Antoine, you didn't mention any gram stain examination and the role of the microbiological lab for traditional way of working, and if this kind of result of gram stain examination may be used in the process at the very beginning.
Yeah, so it's a very good question. Gram collaboration can really help to select a better antibiotics. So if you are working with a lab working 7 days a week, 24 hours a day, and you have some experts doing gram colorations, you can definitely use and implement this correlation and this test to increase and enhance and modify your empiric antimicrobial therapy. Unfortunately, in a lot of ICU or hospital, at least in mine, we don't have access to this test 24-hour days, with experts doing that. And we know that gram negative can sometimes be misleading. So if you are lucky to work with an expert lab for that, it's a good way to improve. Yeah.
Okay, and one difficult question, of course, is that you mentioned that you increase the number of adequate antibiotic therapy with the recommendation, but there was no any benefit about mortality. Do you consider that it may be explainable by the low over risk of death due to VAP, or any other things such as a late diagnosis in our hand most of the time?
So I think several explanations has to be discussed. The first one is, the impact on mortality of hospital-acquired pneumonia, at least at the first episode, is debatable, and the relative risk has been estimated as an increase by 4 to 5%. So it's very difficult to find a treatment that would reduce the risk of death by treating hospital-acquired pneumonia. What we have found in this study is that by applying the recommendations, we reduce the duration of hospitalization in intensive care units, which is not as important criteria as mortality, for sure, or quality of life, but it's still, let's say, a kind of composite outcome showing that the patient is better. So we found that applying this recommendation is still associated with better outcome for the patients.
Okay, so definitely we can consider that an early appropriate treatment is better, and the narrowest one will be probably better in terms of antibiotic selection pressure. So please tell us about the rapid diagnostic test now, Antoine.
Yeah, so you understand that from this state of the art, the main objective of a new test to be implemented in such approach, so it will not change completely our way of diagnosis and treatment in something that needs to be added to this approach. And the main objective will be to reduce over-treatment, because you remember that roughly 50 to 60% of the patients are over-treated, while only 3 to 5% are undertreated. So we would need something which is to be standardized, because you discussed for the gram-negative, which is difficult, is man-powered. So you may have some modification in inconsistency regarding the test. So we would like to have a standardized test, rapid, because if you need to implement, it means that you need to have the result in the next few hours after respiratory sampling. In an ideal world, this result should be accurate, meaning that it would be concordant with what we find with bacterial cultures. Ideally, could work on polymicrobial infection, because we know that in pneumonia, you have frequently 1 or 2 pathogens over the thresholds of cultures. It may also help to test and predict the susceptibility to antimicrobial therapy, and ideally it should be cost-effective and easy to implement in antimicrobial stewardship strategy, because sometimes when we have too many informations, it can become very difficult to think about the results and the way you will implement this data in clinical practice. So on the next slide, you will see that rapid identification of pathogen by PCR is now well known, it's feasible. We all know that for COVID-19 pneumonia, we can have access to PCR in less than few hours to know if our patients are positive or negative for coronavirus. So we can use these techniques to also identify bacteria. And so it means that if you can have viral identification by PCR in few hours, we have the same approach for bacteria. If you developed a kit searching and looking for a wide range of bacteria you are susceptible to find in hospital-acquired pneumonia, you may have a test that will be standardized, reproducible, and easy to use in daily practice. On the next slide, you will see that it's an example of the PCR multiplex, which is called Pneumonia Panel Plus, which has been developed by Biomario supporting these presentations. In this test, roughly 30 pathogens and genes of resistance, of antimicrobial resistance, can be assessed, measured, and the result can be obtained in less than a few hours. And this test has been designed for the most frequent pathogens involved in hospital-acquired pneumonia, or on some of them, such as atypical bacteria or viruses, are more associated with community-acquired pneumonia. And this test is enable semi-quantification of bacteria, and also the presence or absence of some antimicrobial resistant genes such as ECMEC and MRGE, which is associated with resistance for methicillin, some of the genes for extended spectrum beta-lactamase, and some of the genes for carbapenemase. So we have a test there that can give you in few hours the presence or absence of some of the pathogens, but you will only find the one which are in this panel, meaning that if you have bacteria or gene of resistance which are not tested, you will not know that. So it gives you a lot more information that you can have with gram staining or risk factor, individual risk factors, but it's still incomplete. So you are now better fit to adapt your antibiotics, but you may have to face some pitfalls. And so these tools may be perhaps difficult to use in clinical practice. So on the next slide, I will show you some of the data we have produced to test the feasibility and how we can better use this approach in our recommendations. So we performed prospective cohort studies of 100 patients with suspected hospital-acquired pneumonia, and we test by this rapid PCR panel plus test in bronchoalveolar lavage or endotracheal aspirates the patients at the time of diagnosis, which is DS, or 3 days later for the endotracheal aspirate, which is TT. And the first result was how frequently we can find some pathogens, how frequently we can find negative results. Because one of the main messages we were interested in is sensibility of the method, because PCR is a very sensitive method. And one of the fear we had at the beginning of the project was we will always find some pathogens, meaning that we will not be able anymore to find that this respiratory failure is not a pneumonia induced by pathogen, because we will always find some pathogen. And you can see in white that finally roughly 20% of the case using this PCR diagnosis find negative results. So even with these sensitive methods, we still can find some patients who were not finally infected by bacteria. On the next slide, we try to now compare the result of this rapid multiplex PCR with what we found on the same respiratory fluids using classical culture and bacterial identification as the standard of states. You can see that finally in roughly 40% in BALS or endotracheal aspirates, we find some discordant results, meaning that at least one bacteria find was different between the two techniques, so PCR or culture. Most of the time, it's on the left, we find some bacteria with a PCR, which was we found the bacteria in culture. We find sterile and no infection in culture, while we found some bacteria in PCR. And PCR was better for to select 3 or 4 pathogens. So finally, we found some, let's say, expected result is that PCR is more sensitive. You will find more frequently pathogens, but it's also better to find and discriminate the situation when you have polymicrobial infections. On the next slide, we look at what are the pathogens the most frequently found. On the right side of the panel, you can see that we found some of the bacteria which are present in culture and not found in PCR because they are not part of the panel. For instance, Stenotrophomonas maltophila or Citrobacter causeri are not in the panel, so they cannot be identified in the PCR, but they were found in culture. So it's clearly something you need to know, that this kind of PCR approach do not find everything. They are just finding what they are looking for. And if you don't find anything in PCR, it doesn't mean that you are nothing in culture, because some pathogens are outside of the scope. On the left side of the slide, you can see that Haemophilus influenzae and Staphylococcus aureus were more frequently found in the PCR test than in culture, showing that probably for these 2 pathogens, the PCR is more sensitive than the culture. So it's one of the tricks, one of the pitfalls of the techniques. It's not exactly what we will find in culture. You have some all in the spectrum, and so for some of the pathogens, the PCR is more sensitive. On the next slide,
Antoine.
Sure.
Probably there is for me a difficult to understand message, which is the false positive result of one PCR, especially if the patients have received antimicrobial within the next 48 hours. And we have very frequently, especially for early onset pneumonia and for hospital-acquired pneumonia, some patients that received empirically, of course, 1 dose of one particular antimicrobial with finally a negative culture or a culture below the threshold and a very positive PCR. So what are you how are you interpreting in routine the let's say false positive results, because it is really an issue in routine?
Yeah, so it's true that if you use an antibiotics and you kill the bacteria, you will not find any more in cultures, but PCR can still find the genomes. So in these settings, and the next slide, but I will show some of the data on that. It means that should we always consider culture as the gold standard? And let's say I agree with you. I'm not sure of that. Sometimes cultures can be false negative. If your patient is receiving some antibiotic for other things, we may have a culture which is wrongfully negative. And so it's what we call discordance between the two tests, meaning that they didn't find the same results, but sometimes PCR had the good results and culture is falsely negative. So you may have to consider the medical history of the patients and the quality of the prelevements too. So on this slide, it's just to show that finally the total accuracy of the test is relatively good, because the accuracy is 96% in total for all the pathogens in the scope of the spectrums. And on the slide after that, you have better representations, on the next slide, better representation of the impact of antimicrobial therapies on the results. So as I see in these cohorts, we collect respiratory fluid from the trachea of the patients at day 3 after the initiation of the treatments. And so we repeat PCR and cultures. And in these settings, for 57 patients out of the 100 patients, we found bacteria detected by PCR, but not in culture. So for 50% of the patients, we were not anymore able to find these pathogens. But when you look at more precisely 51%, so 90% of the cases, the bacteria found in PCR were the one present at the day of diagnosis. Meaning that after 2 or 3 days of antibiotics, you can still find the bacteria in PCR, you can still find the genomes, but you cannot make it grow anymore in vitro. So finally, you can use this as a pitfall, consider that as a pitfall, but it could be also useful because sometimes you have a patient which is not under invasive mechanical ventilation, so you cannot access to this trachea and it's difficult to collect and have a definitive diagnosis. Finally, these patients develop a more severe respiratory failure and you need to place it under invasive mechanical ventilations. And at this time, after 2 or 3 days of antibiotics, you can access to the trachea, and with PCR you can make the diagnosis relatively efficiently, because most of the case you will find the pathogen which were present 1 or 2 days earlier. So it's something that you need to keep in mind, that for sure PCR will remain positive for longer duration than cultures, and it's not impacted, or at least less impacted, by previous antimicrobial therapies. And we also look at the discordance at the time of the diagnosis. So it's on the right part of this slide, and you can see, for instance, that relatively the same message for bronchoalveolar lavage or endotracheal aspirate. That when you look at the discrepancy between the culture and the PCR, it's on the right side. In roughly 20% of the case, either the bacteria found in PCR was present in culture, but not, the result was not provided by the microbiologist because he didn't consider it as pathogen, in case of Streptococcus, for instance. So finally, it's not a negative in culture, it's just not, the result has not been considered by the microbiologist. And in sometimes, the respiratory fluid was such polymicrobial that microbiologists only identified 1 or 2 pathogens, and the third one was not found, but it was present. So finally, only 10% to 20% are real discordance between culture and PCR.
You have a question in the chat about the sputum use.
So
do you think it is feasible to use sputum?
Yeah, so we found relatively the same. So we did, the quality of the prelevement between bronchoalveolar lavage and sputum was not significantly altered in this cohort of 100 patients. So yeah, definitely you can use sputums for this approach. So from this first cohort, we found that finally you have some pitfalls. You need to know how it works, but it seems to be relatively accurate, standardized, so it seems to be promising. And we say that now we need to think about the way it can impact our empiric antimicrobial therapy, because it's not so easy. If you know that your patient has a MAC-HAC positive genes, not all the clinicians know that it's associated with medicine resistance genes. And this is usually a Staphylococcus aureus resistance to methicillin, but it could also be associated with a coag-negative Staphylococcus aureus. So you have some tricks. It's the same for CAPT and OXA48. Not all the clinicians know that it's carbapenemas. So we decided to develop a guidance for empiric antimicrobial therapy. So it's what we present in this slide. So it's what we find in my hospital. It needs to be adapted to each circumstances because you need to know what is, for example, for Pseudomonas aeruginosa, the classical susceptibility of your strains. If you are working in a hospital where Pseudomonas are mostly resistant to ceftazidime, for sure you would not recommend that if it has been identified by PCR. So we developed this guidance for empiric antimicrobial therapy with our microbiologists and experts in infectious disease regarding our local ecology. And in the next slide, we decided to test what have been induced if we have followed this guidance. So we use the same 100 patients and we make simulations. So we look at what has been done in real life. We say, all right, if we have been fully compliant to international recommendation, what should have been done? And if we have followed this guidance based on PCR, what could have been done? And we simulate empiric and adapt antimicrobial therapies. And you can see on the right of the slide that we expect from this PCR approach a reduction of the number of days of broad-spectrum antimicrobial therapies. So it could be expected because you remember that 60% of the patient will receive 2 broad antibiotics if you follow recommendations. So on the next slide, we continue to work on this hypothesis that PCR can reduce the duration of antimicrobial therapy. It's also supposed to be associated with a decrease in the unnecessary broad spectrum. It's classical. And one of the results we also try to test is the cost of this PCR. And we make a simulation if we use the cost, this PCR for all the patients with hospital-acquired pneumonia. So it would induce an increase in the cost of hospitalization per patient for more than 1,000 euros in France to save 1 day of broad-spectrum antimicrobial therapy. So it could be estimated as costful, but remember that for this estimation, it's if you use the test for all the patients, even if the patients have no risk or very high risk. So perhaps these cost estimations could be reduced if you are more targeting your patients. So on the next slide, we continue with this project because we say that, all right, it seems to be interesting. And so we try to move the project in real life. And we tested the intervention by saying, all right, we have a before study, which is 200 patients roughly, where we follow the recommendations. And in June 2020, we start to implement and use in real life the PCR test in 2 French hospitals. And we decide that we will keep the same diagnosis criteria, keep the same risk factors, but now we have the results for the multiplex PCR identifications, and we are supposed to apply the guidance for empiric microbial therapy when you use this device. And we decided that PCR should only be used in patients with either acute respiratory distress syndromes, because we want to increase the likelihood to identify early the pathogens, or patients with late hospital-acquired pneumonia, because these patients may receive unnecessary broad-spectrum antimicrobial therapies. On the next slide, you will see the results. So we have roughly 220 patients before and 223 patients after. During the interventions, PCR has been used for roughly 50% of the patients. So you remember that we are not supposed to use it for all the patients, but only 62.7% of the patients who should have received the PCR reuse them. So it means that we have an underuse of the device in 35% regarding our recommendations. On the next slide, you will see the impact on patients' outcomes. We are a bit disappointed because we didn't have any impact on the rate of clinical cure, death at day 28, or invasive mechanical ventilation free day, which are let's say, 3 outcomes classically assessed when you want to improve the treatment of pneumonia, but also we didn't find any effect on the duration of broad-spectrum antimicrobial therapies at day 28. So in this project, looking at the impact of rapid PCR when we try to implement it in 2 ICUs, we finally have an underuse of the device, and this could likely explain why we failed to reduce the duration of broad-spectrum antimicrobial therapies. On the next slide, you will see that it's not so surprising because this kind of test has already been tested. The rapid multiplex PCR has been used and developed also for other infections such as septicemia. So in this studies published a few years ago, the patients with septicemia were randomized between classical strategies, rapid PCR, or rapid PCR plus stewardship, meaning that you have an identification, and with the identifications, you call an expert in PCR identification and antimicrobial guidance. And in these studies, with including more than 740 patients, on the next slide, you will see that the approach using rapid multiplex PCR, on the next slide, sorry. So this PCR plus stewardship is associated with a reduction of the time to first appropriate disease escalations, meaning that you need to have the PCR and guidance by an expert to have a full effect of the interventions. If you are just giving the rapid multiplex PCR identification in septicemia, you don't really change the way the patients are treated. On the next slide, it's roughly the same effect, but this one for the total cost. So you don't add any cost, favorable cost if you have just rapid multiplex PCR, but if you integrate that with an antibiotic stewardship approach, you have this time a better effect on the cost of hospitalizations. And to summarize in the last slide of my presentations, so cultures and antibiotic susceptibility are tested in vitro are supposed to be the gold standard, but as we discussed a bit earlier, we are not fully sure of that, and sometimes there can be false negative, or sometimes some pathogens are under the thresholds, but still there. So rapid multiplex PCR is accurate and rapid, so the correlation with the culture is relatively good. If you want to implement rapid PCR identifications in your daily practice, your main objective should be to reduce the unnecessary use of broad-spectrum antimicrobial therapies for hospital-acquired pneumonia. It's likely to be implemented in a global strategy of antimicrobial stewardship and not on specific patients when you have difficult questions. Because in some ICU, sometimes people are using this approach when they say that it's a difficult patient with third episode of hospital-acquired pneumonia under antibiotics. So it helps to have better identifications, but you need to keep in mind that it's not looking for everything, it's just looking for certain genes and pathogens, and you have a lot of, let's say, holes in the spectrum of the PCR identifications. So it's not, in my mind, an approach for specific patients. If you want to implement rapid multiplex PCR identifications, it needs to be for a group of patients that you can define in your specific ICUs, and it needs to be associated with antibiotic stewardship, because it's not so easy to use. You have some new question you are not familiar with, and you need to become an expert with this device. But clearly, you can have the result in less than 4 hours, so it can definitely help you to drive and optimize your antimicrobial therapy. So thank you for your attention. I'm open to question and to exchange, and that's the end of my presentation. Thank you so much.
Thank you, Antoine. You have plenty of questions in the chat. I will start by a practical issue. How long does PCR keep positive after a positive test? How many days of positivity, and is it correlated with clinical cure or not at all?
So in our study, after 3 days, it's still positive for the pathogen you found. So I don't have a clear response for the duration after that, but it's at least for 3 days for sure. It likely could be more. So it's 3 days, even when you cannot find any more the bacteria in cultures. So the second part of the question was on.
Well, I don't remember how long the PCR keep positive was the main question, and the other point should be: is there any impact of the number of copies of or in the MPCR to diagnose the disease? Is there any differences between microorganisms? For example, in my experience, 10 to the 4th copies for Haemophilus influenzae is not really associated with pneumonia and a positive culture. So what is your feeling about the relationship between the quantitative culture and the number of copies in routine and how to use it?
So the device gives you the presence or absence of the pathogen, and you have a semi-quantifications, which is could be misleading at the beginning because you have a result explained in a logarithmic number. So it looks like it's a number of colony-forming units, but it's not this. It's another values. And you cannot have a direct correlation between 10.4 unit from colony-forming units. It's not 10.4 bits in PCR. So you need first to keep in mind that it's not the same values. And I fully agree with you. Some of the pathogens you have, let's say, an oversensitive approach, and Haemophilus likely you need to, if you want to use this quantification, it's likely more 10.6. And for some others, 10.04 is not so bad. So you may have to use the quantification. In our experiment, the way we are dealing with that is mainly, the question is mainly when you have some, let's say, difficult to treat bacteria at a lower thresholds. If you have Pseudomonas at 10.3 and a lot of Staphylococcus aureus, will you consider that? To be honest, in daily practice, when you have a patient with severe pneumonia, even if it's under the threshold, everyone will, or in my ICU, we are still continuing to treat the Pseudomonas aeruginosa because it's so difficult to say that you have this bacteria difficult to treat. It's present, it's likely under the thresholds, but you don't want to see it dominant after 3 days of treatment against Staphylococcus aureus. So the quantifications is not a direct correlations, and it can change between species. And that's, I think, why it's not so easy to implement in daily practice, and that's why likely you need to have a real dedicated teams to discuss the results and take into consideration the entire patients. Severity, medical history, previous antibiotics. It's not a black and white response. It's other informations, useful informations, but it's just part of all the information you need to better treat your patients.
And in the same line, what is for you the way to implement MPCR into the diagnosis and the diagnostic tests that are performed in the microbiological lab? At which part of the diagnosis should we use this kind of new techniques?
So the first point is, I don't think it can be used as a diagnosis of pneumonia. I think the diagnosis of pneumonia is clinical and radiological, and you know that patient has pneumonia. So now you want to have an identification of the pathogens causing the pneumonia, and you have a question. So it means that you shouldn't use this device for all the patients. And the main question we try to test in our studies, in the before-after study, is we need to use a broad spectrum antibiotics, but we know that in 50% of the case, it's useless because finally the pathogen will be susceptible to a narrow spectrum. And we want to reduce this spectrum as soon as possible. So that was our question, because in my ICU, I'm lucky because the rate of resistant bacteria is relatively low. So we don't have any resistance to medicine Staphylococcus aureus. The rate of extended spectrum beta-lactamase is relatively fine. So that's in our ICU, the main goals we have is to reduce unnecessary antimicrobial therapies. I would say that if you are working in an area where you are not as lucky and you have to face a lot of antibiotics resistant pathogens, you may use it in another way around, showing that these patients don't have any specific risk except that you are living in a high-risk area, and you are supposed to use narrow spectrum, but you are a bit scared. You can use this time the PCRs to identify rapidly something that you are more frequently that you have more frequently to face. So the place for this device, I would say, is relatively dependent on the place you are working and living and treating your patients. It's all dependent on the rate of resistance pathogen you have to face. And let's imagine that you are in an ICU where Acinetobacter is the main concern. If it's not in the scope of the PCR, it's probably useless for you to use. But if you are facing a lot of carbapenemas which are in the spectrum of the device, it could be very useful.
Okay, one last point about the turnaround time. You mentioned 4 to 5 hours, whereas the test takes only, in my mind, 75 minutes. So what do you think about the use as a point of care exam, and how to optimize this delay, since 4 to 5 hours it could be considered for a septic shock as very long and too long probably.
Yeah, so the 75 minutes is when you have the samples and place it in the machine, you get the result in roughly 1 hour. But you have to have so when I say that it's 4 to 5 hours, it's our real life. It's the time for the samples to go to the lab, and the time for the results to be communicated, given to the intensivist. So we know that we will have 4 to 5 hours on average, because we have some samples collected on Sunday or during night, and sometimes the microbiologists do not perform it as soon as you receive the samples. The techniques to make it is very easy. It's like making a coffee. So you can imagine placing it as a point of care. But we all know that it's not so easy, because you have a lot of regulations for that. You need to make sure that the device is well and maintained, and the test is still accurate on the time. But if you can have a good collaboration with your microbiologist, and it's something you are keen to, yeah, I think it could be a good point to reduce. Because even if 4 to 5 hours is much faster than, let's say, 48 to 72 hours with cultures, if your patient is in septic shock or with acute respiratory distress syndrome, you will not wait for 5 hours. You will treat. And in our ICU, what we do is in this setting, if we really cannot wait for 3 to 4 hours, we start the treatments, but for the second injections, we change if we have to change.
Okay, thank you very much, Antoine. We will now go to the speech from David Brelet about real-world experience and the way to discuss real-life case report and how to proceed in routine. David is a consultant in anesthesia and intensive care medicine at University College Hospital in London. His research is about sepsis and ARDS, and now he is more focused on the immediate diagnosis and the optimization of therapy, of antibiotic therapy in routine. So, David, your turn to discuss with us some cases and to see how to use it in routine. David.
Jean-François, thank you so much. And Antoine, what an amazing talk. I'm hoping that this case sort of helps build on what you were talking about. So it might marry up quite well. Let's see how it goes. Well, ladies and gentlemen, good afternoon. Welcome, of course. This is the extended clinical case presentation where we're going to see whether molecular pathogen detection on the ICU could be helpful for managing ventilator-associated pneumonia. We've heard a lot about that from Antoine. And really the point is here to explore how these devices may or may not help in the management of these, let's face it, at times very complex environments. Now, we're going to spend a little bit of time doing this. We're going to go into some detail, and there are going to be points where the clinical teams dealing with this case were unsure what to do, as is often the case with infection intensive care. And I'm going to ask you at points, what would you do? And I'm going to ask you to vote on the Slido system. And we're going to give you about a minute and a half to do that. I think what's really important here is to say that, when dealing with infection, there's so much uncertainty. There's no real wrong or right answer, so don't feel I'm judging you or anyone else is judging you on whatever you put down. Really, it's a case of sort of breaking open the discussion and seeing whether we can do better as we go along. So please, just be truthful to yourselves. Put down, just vote the way you would have dealt with it. Now, I've got a few disclosures up front. I wouldn't mind a few more, but that's what we've got. As an introduction, yes, I'm David Brearley. I'm an intensivist at University College Hospital, which is in the centre of London. It's a reasonably large tertiary referral hospital. It has a bigger emergency department, but it's particularly well known for the management of cancer and hemato-oncology. The intensive care, again, quite large for a UK intensive care, and is particularly well known for its research and particularly research in sepsis. And the story we're going to talk about pretty much starts in the new year of 2021. And yet again, the UK is getting badly beaten up by another round of COVID. Now, during this time, or just before this time, we were running this trial called Inhale. It was a UK-only multi-center study asking the question, can rapid pathogen detection here using a BioFire film array and a Pneumonia Plus panel, just as Antoine's just talked about, can we use that to improve our management of hospital and ventilator-associated pneumonia on the ICU? Well, it was all going really very well indeed until COVID came along and the trial ended up getting suspended. But it also became very clear when looking at those COVID patients on ventilators that actually this type of technology could be really helpful in managing some of the complications that they come up against. So we opened a sub-study with 4 other hospitals to try and understand what this device would be like if we gave it directly to the clinicians as a point of care device. So if you were a clinician looking after one of these patients and you were worried about a hospital ventilator-associated pneumonia, then you could ask for a BioFire to be run directly on the intensive care, and we would give you that result. And bioMérieux are very kind and supplied a lot of the consumables for that. So really very brief recap of what Antoine's talked about. This is what the device looks like. It is a PCR device and is able to identify a range there of bacteria, some atypicals and some viruses, but along with a few resistance genes. But as Antoine says, if the organism is not on that list, it doesn't matter if you've got a kilogram of it, it's not going to find it. And one's just got to be a little bit aware of that. That said, about 90 to 95% of your sort of nosocomial infections are going to be included on that. So the chances of having escape is reasonably rare. And that's exactly what we did. And this is a picture of Ingrid, one of our nurses, running a sample on the COVID intensive care. We would take the sample direct from the patient, no need for culture, we'd stick it into this machine, and 90 minutes later, we would hand the clinician a printout of the result, and then they could decide what they wanted to do with that result, of course, and we'll talk about that as time went on. Anyway, we're going to talk about antibiotics and bugs. And I think, this gets really difficult if we're looking across the whole of Europe, because the choice of antibiotics is going to be different in my hospital and in your hospital. And it'll all depend on your microbiologist and your resistance profiling and so on and so forth. Now, we're reasonably lucky, like Antoine, we've got a pretty low resistance problem at UCH. It's not absent, but it's reasonably low. And some of you may be working in different hospitals. So it's not about the specific drug, it's about the concepts here. So just bear that in mind. So let's start. 30-year-old male, he's obese, he's got type 1 diabetes. He's got a history of a dry cough, he's increasingly short of breath, and he's got a high fever. He presents to the North Middlesex Hospital, which is a very hard-pressed hospital in North London. It doesn't have enough beds, and it's got a very large and diverse community that it tries to serve. Well, the patient's noted to have a very high respiratory rate. He's got an oxygen saturation of 60% on pulse oximetry when he arrives in the emergency department. Of course, he is positive for COVID-19. He is quickly admitted to the high dependency unit and started on CPAP, which is quite routine at that point. And initially, he did really well. His oxygenation improved and his work of breathing came down, but he just couldn't tolerate the tight face mask and started pulling it off, and it all became a bit messy. So he ended up very quickly being intubated, mechanically ventilated. But this is a small hospital, and they don't have enough beds on the intensive care to deal with this. So they reach out for assistance, and our hospital at UCH is essentially the coordinating centre for this sector of London. And so we agree to take the patient on, retrieve them with an ambulance. So we send a team out to go and get and bring the patient back down to us. And that was all very straightforward. Now, the patient arrives on the intensive care, and I don't think any of these numbers would surprise any of you. High oxygen demand, reasonably tough ventilation, but all other organ systems stable. It really is just pure respiratory failure. He's pyrexial with a fairly high inflammatory load, raised CRP, and so on and so forth. Again, nothing spectacular here when we're considering Delta variant, which of course it was back in the day. He was on some supportive treatments, but in specifics, he was on some dexamethasone. At that time, we knew dexamethasone to be helpful. We didn't know at the moment whether tocilizumab was going to be. But he was also on coamoxiclav and doxycycline as antibiotics. His radiology, difficult to interpret because he's a big person, but it's compatible with COVID-19 at the very least. So he comes down to us and it all seems pretty reasonable. But what do we do with those antibiotics? Well, we know he's got COVID-19, that's clear. But does he have a bacterial community-acquired infection on top of that? Well, the other team started those antibiotics and they must have had a reason to do so. And we stood around the patient asking what is it we should do. And I'm going to ask you the same questions in a moment. Some of the team said, well, look, this is COVID-19. We should just stop the antibiotics. That's straightforward. The other part of the team said, well, they must have had a reason. We should be safe. We should continue these antibiotics and wait for those culture results and then make a decision. And a few went on and said, well, I think we should continue antibiotics, but I think we should change the antibiotic spectrum. Now, I'm asking you these questions to vote on the Slido app. And so please, what would you have done with the information that you've got? Because I didn't have any more than you do. So I'll give you about a minute and a half to make that decision. Thank you. Well, I don't have a stopwatch, but I think that must be about a minute and a half, I'm thinking. Okay, so what have we got on the poll here? Well, it's a sort of even split, but most people, 40% saying they would be safe, continue, wait for the culture results. Just under 40% would say stop the antibiotics, and 20% like to change the antibiotic spectrum. I say there are no right answers or wrong answers here, so don't worry. So what do we think? Well, obviously with experience and now over time, the chances of a superadded bacterial infection in this cohort is actually quite slim, probably about 1% or less. So the chances just statistically are indeed quite small. There's perhaps not an unreasonable concept of waiting for the culture results, but let's face it, if you do a blood culture in a critically ill patient, a normal community-acquired pneumonia in the ED or culture on the ICU, almost 90% plus of cultures, blood cultures are, of course, negative. In my hospital, 60% of respiratory cultures also do not identify organisms, particularly if the patient's been treated with antibiotics up front. And reporting of respiratory cultures is highly dependent on the microbiologist who's looking at the slide. And of course, it takes about 72 hours to get those results back. And is that really going to change what you do? Are you really going to stop your antibiotics 3 days down the line? Well, you might well do, but sort of experience and general research suggests you probably won't. So actually we agreed with 38% of you. We thought we would stop the antibiotics. Now, it's sort of not the hardest question in a way. You've just got to make a choice and go with it. I suppose my one major issue is the concept of should we be safe and continue? Do we ever say, let's be safe and continue, my hospital, chemotherapy? Well, our oncologist might, but anyway. Should we be safe and continue ventilation, anesthesia? Should we continue noradrenaline? Should we continue renal replacement therapy just to be safe? And the answer is almost invariably no. Don't be crazy. As soon as you start any of these interventions, you're looking for a way to stop them because the side effects, we all know that ventilation is appallingly bad for you. Well, why don't we ever say that about antibiotics? They carry very significant, serious direct toxicity to the patient, drug-induced nephritis, liver dysfunction, overgrowth of bacteria that we don't want, C. diff and so on and so forth. And of course, the damage to the local and the wider microbiome and antimicrobial resistance and so on and so forth. So it's an interesting paradox that we think of many of the drugs that we use are bad, well, because they often are, but somehow we feel safe giving antibiotics. But it is a tricky one. Here, the biofire was of absolutely no help whatsoever because there was minimal in the way of respiratory secretions. So it was very frustrating, but that's life. Okay, so we did stop the antibiotics, and in the end, no harm came to the patient. He slowly improved over the next few days. However, around day 5, following his transfer to us, the temperatures started to go back up again. His endotracheal aspirates thickened up, became quite marked, thick, brown, really quite unpleasant. His ventilatory requirements thankfully remained stable. His chest x-ray pretty unremarkable, and there were no other organ dysfunctions. He just had essentially isolated raised temperatures and increase in the rate of secretions. Now, if you spend millions of euros or pounds on an electronic health record system like EPIC, like we have, you can get a nice temperature chart that looks like an Excel spreadsheet. And this is ours. So here he is, 5 days down the line, and his temperatures are up to 39 degrees. So we say, dear microbiologist, what do you think we should do with this? And the microbiologist says, well, look, I think these are probably COVID temperatures. So I wouldn't give any antibiotics at this point. Now, CRP and white count remain elevated but unchanged. Do you agree with the microbiologist? Would you have done the same? So if you get the Slido out again, if that's okay, and have another vote, yes, why don't we just not give antibiotics, send some cultures and wait and see, or no, actually, no, I think we've got something more at work here. So to give you another minute or so. Well, that looks like it's got most of voting done, and my speedy anaesthetic stopwatch suggests it's about a minute and a half. Right, so 64% of you thought, no, the microbiologist got it wrong, and a third of you said, yeah, that doesn't seem unreasonable. And again, you know, there is no wrong and right answer to this. So we got all terribly excited because we've got a biofire. So let's take that sputum and put it through it and find out what happens. And in 90 minutes, this is an excerpt from our medical notes, our nurse comes back and says, oh, well, I've got 10 to the 7. And remember, this is not CFUs, these are copies, but 10 to the 7's, you know, the maximum amount the machine will report. 10 to the 7 Haemophilus influenzae, Klebsiella pneumoniae, and Proteus. Well, Proteus Klebsiella, okay, that seems reasonable. Interesting, we've got some Haemophilus in there too. But that result allowed us to phone up the microbiologist very quickly and have that discussion. You know, look, we've got a little bit more information here now. What do you think? Should we start the antibiotics? And he, you know, very quickly said, yeah, actually, you know what? That's useful to know. I think with that mixture, we're going to start some meropenem. And indeed, that's what we did, and the temperatures settled down. Was that the right call? It would seem so, but again, unclear because there was no obvious sort of organ dysfunction on top of it. Okay, life carries on. He remains very sick, but at least he's stable. Then a few days down the line, yet more high-grade temperatures. Now the CRP is climbing, his FiO2 is climbing. Okay, his lungs are getting worse. Thankfully, his galactomannan and beta-D-glucan are low, so the chances of this being a fungal infection are pretty slim. And his procalcitonin, which is something the UK doesn't usually do, but for some reason we decided we would here, is also quite low at sort of 0.11. So, dear microbiologist, what are we going to do with this? Well, says the microbiologist, look, the procalcitonin's pretty low. I think you should not give any antibiotics, but look, well, I got it wrong last time. That was completely fair enough. So if things are going wrong, start some ciprofloxacin. Well, it didn't take too long. By the evening, the patient was deteriorating, so the intensive care team decided to start that ciprofloxacin as suggested, but also run a biofire. Well, 90 minutes later, we got this. This is sort of a copy of what comes out of a biofire. What it is showing is that we've got over 10 to the 7 copies of Pseudomonas aeruginosa. It also suggests he's got a bit of a rhinovirus. So he's got a bit of COVID, he's got a bad cold, and he also seems to have some Pseudomonas in there. Now, the ICU team now feel both validated and vindicated in starting the ciprofloxacin, and they feel very happy with themselves. But the question to you is, were they right to do that? Were they right to start ciprofloxacin? I appreciate things may be different in your country in terms of protocols, but were they right to start that concept? And there's a number of options here. You could say, no, look, that's stupid. It's clearly COVID and rhinovirus, and the Pseudomonas is completely irrelevant. Or you could say, yes, that seems a very sensible idea. You could say, sort of, but no, there may be other organisms involved. Dave, you said that that BioFire is a PCR device, won't pick up all organisms. So I need to extend the spectrum just in case. Or you could say, no, the Pseudomonas may be resistant to ciprofloxacin, knowing that that might be the case in less than 10% within the UK, according to ECDC. So please have a vote. I'll set my stopwatch and we'll talk again in a minute. Right, there we go. So just looking at the results, it looks like about a third or 35% think, that's not a bad idea. The ciprofloxacin was the right thing to do. 27% said, no, look, be careful, there could be other organisms involved. I need to extend that spectrum. A similar amount, 27% said, no, that Pseudomonas may be resistant to the ciprofloxacin, about 10% in the UK or less. And 12% of you said, he's got a bad cold, and it's COVID. Okay, let's see what happens. So here we go. They start the ciprofloxacin, and the temperature looks like it starts to settle. A little while later, it starts to spike back up again, and after a day or so, the white count is beginning to climb. So what's going on here? Now, unfortunately, the intensive care team had listened to them, correctly listened to the microbiologists, but did not re-engage them on this discussion and carried on the ciprofloxacin. 3 days down the line, when the culture comes back, we find, yes, lots of Pseudomonas aeruginosa in there, just like the BioFire said, but it is resistant to ciprofloxacin. Now, of course, the BioFire can't tell you what the susceptibility is. It can just tell you it's got certain resistance genes associated with it. So BioFire was correct in what it said. Unfortunately, we got the wrong antibiotic. Now, resistance to quinolanes, say in the UK, is variable and is touted at less than 10%. But what the ICU doctors were not aware of is that locally here at UCH, it can be around 20%. Now, that is important because the BioFire gave the right information. They told them there was Pseudomonas there. It just was not that well interpreted. And that's why it's really, really important to keep microbiologists engaged with this sort of results. They know the local microbiome, they know the resistance profiling, and I would argue I certainly don't, and probably you as intensivists might not either. So again, it becomes really important that even though you know the organism might be relevant in there, that you continue that discussion with microbiology. Anyway, they switch to ceftazidime, and the temperature starts to fall, the white count comes down, and things start to get better. All right.
David, two questions. First one, is there a place for a B antibiotic therapy, either to start to cover this Pseudomonas aeruginosa infection after a first antibiotic therapy? And the second question for you was about the use of procalcitonin daily or repeatedly in order to try to stop early the antibiotics.
Yes, okay. So I'm sorry, I might have missed the first question, but it was whether you should use 2 antibiotics.
Yes,
is that correct?
At the point of the use of the choice of Cipro, perhaps after a prior antibiotic therapy with Mero, and the risk of Mexabe-OPRM and efflux pump inhibitor and so on, perhaps it could have been prudent, let's say, to use B antibiotic therapy for Pseudomonas aeruginosa.
Yes.
What is your point about it?
Yeah, of course, this was the first time that one found Pseudomonas in this patient. It was Proteus and Klebsiella beforehand, but you know, clearly this chap's been on a ventilator for a while and there's high risk developing it. Now, of course, everyone does things a bit differently, and we tend to use single therapy, certainly to start with. Again, trying to limit antibiotic spectrum. It's all about antimicrobial stewardship. Sometimes, of course, that works. Sometimes, of course, like this case, it doesn't. And it is trying to make a call here, which is really difficult with classic microbiology, because you've got a 72-hour delay before you do or don't get any culture results back. And I wonder if we just keep going with this presentation, whether again, it might just show this technology could be helpful. Procalcitonin, the UK never uses procalcitonin, probably because it's too expensive. Why we decided to suddenly use it as a diagnostic for bacterial infection, where we've generally been pretty rude about that concept, all of a sudden unclear. But we did. You're also right, and why weren't we tracking procalcitonin to stop antibiotics early? Well, again, it's all very different, isn't it, across the whole of Europe. You've got obviously really nice French trials there showing that procalcitonin can reduce 3 days off your antibiotic duration or thereabouts. Dutch trials showing less of an impact, and some Danish trials showing actually it might even be a bit harmful and increase your antibiotic duration. And it all depends on what your sort of standard course is. In the UK, our standard course here is about 5 days. And so we're saying, I doubt procalcitonin is going to make much of a difference. That said, we are running a UK trial on exactly that at the moment. So I think we'll just hold on trying to answer that question for sure. All right, let's carry on. So if it couldn't happen, life is getting harder for this poor chap. He gets a pneumothorax, he gets a chest strain. He's on 100% oxygen, he's prone ventilated. His right heart is suffering, he's getting some inhaled nitric oxide. His blood pressure is falling, he's on noradrenaline. And then, just to make matters worse, the temperatures come back yet again. Again, beta-D-glucan, galactomannan are negative, so the chance of a fungal infection at this point, and of course he is at risk, is pretty low. Procalcitonin, whatever we've just said, is starting to go up, and people are beginning to worry maybe that does reflect a bacterial infection. Now, we've been very busy with the BioFire on lots of other patients over this period of time, and unfortunately, we'd run out of BioFire cartridges. And Jean-Francois, the microbiologist, listened to you at this point and decided, look, we've had lots of courses of antibiotics, we have bugs that are difficult, so we're going to start some meropenem. And that is on the background of the microbiologist will get chastised for prescribing a carbapenem here, because it's all about trying to reduce using it. So people really think long and hard about this, and they scratch their heads, and people get very worried about doing this. But anyway, it seems like a right choice. And the respiratory cultures go off to the lab, and indeed they do come back a few days down the line saying Pseudomonas aeruginosa, sensitive to meropenem. And we can see the impact that meropenem is having there on the temperature and the white cell count, and the patient stops getting any worse and slowly starts to improve. So that's great, good choice. But if we look a bit further into the future, well, a few days later, the temperature is up again. And now the white cell count is beginning to rise again. they change all the venous lines, the central lines, and so on and so forth, and they send a full septic screen. So again, all the sputum and the blood, etc., go off to the lab. Now, what should we do? And of course, I'm going to ask you, what would you do in this case? Should we change that meropenem? Something seems to be escaping it. Should we add another antibiotic? Maybe we've got something here that we don't know about. Should we add an antifungal? You know, is that beta-D-glucan? Is it really that good at negative predictive value? Or should we carry on the meropenem and wait for the results? So I'd encourage you on the Slido just to have a go and think, you know, what is it that you would do at this point? We'll give you another minute and a half. All right, so that's about a reasonable amount of time. What have we got? So 43% of us thought it would be not unreasonable to carry on essentially and wait for the culture results. 39% of us thought, well, let's add another antibiotic to it. 11% of us thought, let's add an antifungal. And 7% thought, let's change the meropenem to something else. All right, let's see what we've got, because actually what we do is we've now got some BioFire cartridges. So let's put the sample through the BioFire, and in 90 minutes, what do we find? Well, we find 10 to 6 copies of Pseudomonas aeruginosa. Still got Pseudomonas there, and that's quite a lot of it. 10 to the 4 Klebsiella pneumoniae. I don't know the relevance of that. There's not very much of it, but what else? It looks like we've also got an OXA48-like resistance gene, and that starts to get really interesting. So, of course, the OXA48 gene was discovered, what, about 20 years ago now in Turkey, and since then, I don't know the absolute numbers today, but over 35 OXA48-like genes have been discovered. And an OXA48 is essentially encodes a carbapenemase, an enzyme that hydrolyzes carbapenems and penicillins alike. The OXA48-like enzymes or carbapenemases are very similar, often only varying by 1 or 2 amino acids. That said, the small change in amino acids can make a really big change in the way that gene impacts on your carbapenem. OXA48 is transferred very efficiently and rapidly through plasmids, both interspecies and intragenous, most common in an Enterobacterales like the Klebsiella, but it is also found in Pseudomonas, so it could indeed be there. Common cause of carbapenem resistance, I think, in Europe, North America, and Middle East. So there's quite a lot of it around, and it is problematic. So we've got quite a lot of Pseudomonas. We've got what looks like meropenem escape to meropenem, and we've got an OXA48-like gene. They're probably all related. So the OXA48 is probably most likely associated with the Pseudomonas. The BioFire cannot tell you. It just tells you the gene is there. It does not tell you which of those organisms, or even both of them, it is carrying it or necessarily expressing it, but it is there. All right. We at last get this one right. And we're immediately on the phone to the microbiologist with that result, who says, yes, that is a problem, and the meropenem's not going to work, so please stop it and give ceftazidime avibactam, send a resistance profiling screen, and really important, and again, this is why we speak to microbiologists, this thing spreads around like wildfire and you don't want it on your intensive care, so strict barrier nursing, please, and put them off in a side room. And that's
there is a question about the way you are taking care of gram-positive in this setting. Do you consider that the risk for Staph aureus is negligible, that there is no risk for having MRSA in this case? Because you didn't mention any use of antimicrobial that is active against MRSA. So what is your view? It is a question from the web.
It's a very good question, of course. So, of course, we considered gram positives, and in many respects, that's why we immediately changed the lines when we started to get worried about temperatures again. We were hoping that just changing lines, if there was a line infection, would have controlled it. Of course, the BioFire is able to detect Staph aureus, and indeed it is one of the commonest organisms. So if we look back at all the organisms found during COVID and indeed before COVID with the BioFire, Staph aureus is almost always number one, but it didn't find it here. Does it mean it doesn't exist? Possibly, but this is a very sensitive device. It's pretty good at finding Staph aureus. We've also got a pretty good culprit. So yes, it's not an unreasonable thing to say, but look, we can't find it. MRSA itself is now, it used to be very common in the UK. Thankfully, it's reasonably rare. So again, thinking it's probably unlikely. So we just went with gram-negative cover. We just blamed the Pseudomonas and the OXA48. And it looked like that was probably actually, in retrospect, the right thing to do. We started ceftazidime avibactam, the temperature started to settle, the white cells came down, and the patient gradually improved. You're of course absolutely correct that by now, why don't we have something like a Stenotrophomonas coming up behind us, and we won't be able to detect it. Thankfully, the cultures came back 3 days down the line. Yes, lots of Pseudomonas still, and look at that, is resistant to meropenem. And I think this really starts to show the power of these molecular detection devices. Within 90 minutes, we were able to detect the organism. We were able to find a resistance gene that had a major impact on the antibiotic we prescribed, and had that discussion and had it changed days before standard microbiology was able to tell us that's the case. And I think that's, this one in particular, I will remember of how the BioFire really helped us to develop. Again, meropenem resistance is pretty rare here. This was the first case that we had during the pandemic. It wasn't the last, and the others, we picked up a number of other OXA48 likes as we went on. Fungal infection, also incredibly rare, running way less than 1% in our cohort. So again, there would be a question. Some people ask, well, why didn't you treat a fungal infection? Well, because we weren't really expecting it, and we'd had no evidence of fungal infection up to that point. And so the patient carried on, and another month or so on the ventilator, but actually did do well, survived, got home, and got back to a very good quality of life. So it's, all's well that ends well. But I think what this case really does demonstrate, certainly to me, is how this type of molecular pathogen detection can be really important. But it also says that it's not just about the technology, but how it's interpreted in the field. And for that, you need experts, and we call them microbiologists. And some people say, well, this technology is going to replace the microbiologist. That's absolutely not. This makes the microbiologist almost more important than they've ever done before. And I just wonder if we've got just a moment to have a look at a case that just, very quickly, a case where it didn't help. A very similar patient, several weeks on the intensive care, COVID, awful multi-organ failure. And I'm on, it's midnight, and I don't do night shifts very well, but I'm there, and the nurse grabs me and says, David, look, this patient's so sick, the noradrenaline's going up crazily, he's on 100%, I think he's going to die, but he's got these temperatures, what do you want to do? And I said, oh, well, look, don't worry, I'll run a BioFire. Now, you probably can't see on the camera, but I am quite grey. And this concept of using new technology and doing complicated things at 12:30 a.m. really is not for me. But it's so easy. We just take the sample, we put it in the machine, we press go, and we wait an hour and a half, and the result comes back. Nothing. No bacteria, no viruses, no atypicals. And I'm not sure what to do with that result. It's really difficult. Well, yes, it could be Stenotrophomonas in there, but it's unlikely. It's very, very rare in our unit. Could be fungal, but again, incredibly rare. So what do I do? Well, the scientists in me are saying, well, hang on, this is just COVID. This is a man who is dying of overwhelming COVID and inflammation. You know, this is not driven by a bacteria. But as we said earlier about being safe, and I'm now going to be a hypocrite, I say, well, look, he is very poorly with rising inflammatory markers, and despite a negative biofire, I myself say it is difficult to withhold antibiotics, and I start him on some ciprofloxacin, and you can argue against that. The cultures came back a few days later after he died, were negative. The man, I think, probably didn't have a bacterial infection.
Okay, David, I must interrupt you because it is more than 5 now and will we be cut?
Then we will be thrown off, but I am finished. I am finished.
So, a wonderful overview of the possibility of these new techniques. We are moving from the empirical therapy to the early targeted therapy, and it is especially the case for pneumonia. I think we have to learn of it. We have to, of course, to work with the microbiologists and the infectious disease practitioners in order to perform a good, appropriate stewardship program, integrating this kind of system in the diagnosis. Well, it is time now to close the session. Thank you, Antoine, for your nice presentation. Thank you, David, for your case reports that were really interesting and helpful for trying to look at the way of using these new techniques. And thank you to all, and I wish you a good day, and see you for another live interactive session in the next future. Bye-bye.
Thank you all.
Thank you, bye.